એ આપણે હું તરત એ લાઈવ તો તરત લિંક પર કરી જ દઉં છું હમણાં.
અચ્છા, એટલે દેખાશે ને મેડમ?
હા હા મેડમ દેખાશે. અત્યારે રેકોર્ડિંગ કરીએ છીએ આપણે, પછી એને આપણે ત્યાં મૂકીશું. એટલે રેકોર્ડિંગ પત્યા પછી સર થશે.
રેકોર્ડિંગમાં તો અડધો પોણો કલાક જશે ને પણ?
યસ સર.
એટલે એના પછી આપણે કરીશું?
યસ સર, એના પછી થશે. એટલે જ પ્રોબ્લેમ થાય, લાઈવ નથી થતું એના પર.
ઓકે, તો આપણે 5:30 વાગે કહીએ બધાને?
આપણે બધાને ચેન્જ પણ હા 5:30 વાગે મેસેજ કરવો પડશે. યસ સર.
ઓકે ઓકે
ઓકે. Recording started, ma'am.
Okay. So, good afternoon, everybody. It's indeed a privilege to be here with you through this focus on first trimester, the right protocols. And we decided that despite the COVID pandemic that we have across, this happens to be an important juncture in pregnancy and our knowledge and education has to move on. And therefore, we decided to choose this topic on first trimester focus. My slides are not going aage, huh? This is Dr. Girija Wagh, and I happen to be from Pune OBGYN Society, and it's definitely with whatever experience I have and with all the recent updates, I bring in this presentation to you. Now, we all know that the reproductive health priorities are to target the care to pregnant women who really need it and were proven to be effective. Safe pregnancy for the mothers and the birth of a healthy fetus at term are our objectives. Now, we can see that maternal mortality has been brought in to quite some control, and especially in countries like India. And there is a 44% reduction in the maternal deaths. But at the background, under the entire tip of the iceberg, we know that there is a huge lot of morbidity, and most of this morbidity gets contributed by obesity, diabetes, hypertension, giving rise to hypertensive disorders, small for gestational age pregnancies, preterm deliveries in babies who are finally going to be programmed to these diseases in the future. Unplanned pregnancy, usually the damage may already have been done, and early embryo exposures to alcohol, certain medications like antihypertensives, anti-epileptics, improper diet habits, micronutrient deficiencies, stress factors, cigarette smoking, environmental factors may usually cause affection to this particular embryonic period. Usually we find patients coming to us towards the end of the first trimester, maybe around 8 to 10 weeks, but sometimes we do get an opportunity of dealing with them before that. Now, this other challenge that we have in our country is obesity, and it's a huge problem, similar or in fact more than malaria or tuberculosis. And there's a tidal wave of obesity, be it in the rural part of the country, be it in the urban part of the country. We are having a huge lot of insulin resistance driven visceral obesity. And that is something which is not only affecting our adolescents, but they are also affecting our women in the reproductive age group. And probably we need to attribute to the typical Asian Indian ethnicity that we have to deal with. If you look at the miscarriage rates country compared to the global rate of 10%, Indian women experience about 32 to 35% of miscarriages. And these are because of structural defects, infections such as tuberculosis. And naturally, one wonders, can we not bring on something which can prevent such kind of outcomes? The plausible causes of early pregnancy losses have been identified to be obesity, smoking, alcohol, caffeine. Exposure to certain occupational hazards may increase the chance of early pregnancy losses, and this could predominantly concern the unexplained losses. Now, rubella infections, and especially the congenital rubella syndrome in the babies, is something which can be completely avoided. But unfortunately, even today, when we take a survey of women coming to our antenatal clinics, even in the high socioeconomic conditions and classes, we find that only about probably 1 or 2 of 100 women would probably be vaccinated against rubella vaccination. And there's a huge dearth of ignorance, a huge dearth of knowledge about this particular intervention, despite the government going far ahead and the vaccine not only being proposed to cover the children going in school, but also being sort of advertised everywhere, made available, and it's extremely cheap, but still we find that women have reluctance towards taking this rubella to protect their unborn babies. Neural tube defect prevalence is high, and you will be still surprised that despite having an access and availability of folic acid preparations, knowledge, know-how, many women, learned or otherwise, seem to be presenting to us without any periconceptional medications. And you can see here in the graph that in various countries there has been an observation. These blue lines show that there is much rise in the neural tube defects prevalence, which is controlled by the green lines when folic acid and folates have been supplemented in the periconceptional period. Much has come forth now with the Nicolaides group talking about turning the pyramid of prenatal care, and starting from the NT scan and the screening from Down syndrome. Now we have reached to prevention and identification of miscarriages, fetal deaths, fetal growth restriction, preeclampsia, preterm deliveries, macrosomia, gestational diabetes, major and aneuploidies, and so many other issues. While more men die because of what one may call their vices, women often suffer because of their nature assigned physiological duty for the survival of the species and the tasks related to it. And first trimester offers this window of opportunity. After the Nicolaides reversal of triangle, there is a new proposition of the first 1,000 days of your existence, from the time that you are in the periconceptual window till the time that you were in the prenatal point, birth, and beyond birth up to 6 years. In these 1,000 days, we find that there are huge windows of opportunity wherein one can optimize health. Why first trimester? Because first trimester is a time when you can optimize the maternal health if she's suffering from any illnesses. Placentation is forming, which is going to be the baseline and the background of the successful pregnancy outcome. And organogenesis, where the fetus is multiplying to form its organs, is the period which is very, very common and most vulnerable in the first trimester. So it's a period of organogenesis. Placentation offers opportunities for screening for future diseases and risk assessment. Interventions to optimize outcomes and corrections for better outcomes can be undertaken during this time. It is imperative that a proper and a detailed menstrual history is taken, because it's important that we establish that the pregnancy is inside the uterine cavity, especially in women who have had recurrent losses or adverse outcomes. It is important, and with irregular cycles or undergoing infertility treatments, we need to find out whether it's implantation bleeding, whether she's miscarrying, whether it's an ectopic pregnancy or a dysfunctional uterine bleeding. And we also need to correctly date the pregnancy, obstetric history, all the adverse outcomes. Usually, sometimes women tend to forget them. They do not even remember that they had eclampsia or they had birth traumas. And we require to probe and take this history, because previous C-sections, whether they had admissions in the ICU, HDU, whether they had any blood transfusions, whether they were morbid after that, all these histories are extremely important. Even Rh isonimmunization, many times women find that it is not important that they inform the doctor. Now let's look at Mrs. Ripple, who is a 28-year-old XYZ, married since 6 years. She has a history of 7 months spontaneous preterm birth and 3 miscarriages. 2 of them have been missed abortions. And her menstrual history and everything has been looked into. She has a history of childhood asthma, and there is a family history of diabetes and hypertension in her family. Her platelets were 1.2 lakhs. Her autoimmune profile was done, and she was found to be positive for all the kinds of lupus antigens, and ACLs were high. So what is this? Naturally, the condition that comes to our mind is APLA. And the question comes, does APLA cause early pregnancy loss? Probably yes, because inhibition of cytotrophoblast invasion and differentiation is seen associated because of thrombosis. And there is a imbalance in the prostaglandin release and giving rise to inflammatory processes which lead to placental cell apoptosis. So the character of pregnancy loss, typical presentation is growth restriction, probably leading to fetal death in the 2nd or the 3rd trimester. 10% of the unselected patients may present with RPL, and APS in 30% of patients with recurrent 2nd trimester pregnancy loss has been observed. There can be defects in other coagulation disorders like thrombophilia or non-pregnant risk of GVT, which require to be analyzed through proper history, and MTFHR gene abnormalities or acquired hyperhomocystinemia can also be the reasons which require to be investigated and tested. Now you can see here that this is Mrs. Akruti. And this is a published case history which we had experienced. A patient of SLE. She was under treatment with hydroquinone 300 milligram daily, and she had a very bad obstetric history, as you can see here, many miscarriages, no live issues, and currently she was 39 years of age, and this was her finding that was seen at 7-week scan. And you can see that my sonologist kept on saying that I'm not very happy with this scan. There probably looks like an adenomyotic uterus, and there seems to be subchorionic lacunae. And then probably the first diagnosis, she kept on saying, maybe I must keep a look on whether it's a chorangioma or a partial mole, and this was ruled out. And then later on, when this woman had to be delivered at the age of 32 weeks gestation, when the baby had reached 1 kg, before that she had 3 episodes of hemorrhage. We did a planned C-section, and lo and behold, what we found was she actually had a global placenta, and there was a complete thinning out of the uterine wall, which you can see here, and we had to take her for hysterectomy. So this was not only a global placenta, but a placenta accreta to it. Other important histories that require to be looked into are personal past history, especially nutrition, junk, beverages, gastrocolic issues, and dyspepsia, because these are not to be underrated. They are usually related to deficiencies that these women suffer from. Stress, what are their kinds of travel, whether they have undergone any medical or surgical problems in the past, any allergies, asthma, medications, whether they sleep well, and whether they are able to have any physical activity. Family history happens to be very important. Gone are the days when now we don't know what the family history would be, because now we are catering much more with a literate population. And you can see here the March of Dimes on this has given an extensive 4 to 5 pages form on family health history form, which a patient can fill at the time she presents to the antenatal care. Important ones being diabetes, tuberculosis, autoimmune diseases, coagulation disorders, ischemic heart disease, and hypertension, reflecting towards arterial disorders. Now, this is Mrs. Lepsy, a 24-year-old primate with 2 months, gives history of epilepsy, taking sodium valproate, last seizure episode 1 year back. What should be the course of action? We all know that valproate is associated with significant risks for malformation, and if it is a part of polytherapy, then 9% risk of abnormalities. And NTDs, cleft skeletal abnormalities, developmental delays are known because valproate is found to be a folate antagonist. Microcephaly, mild to moderate mental retardation, developmental delays, clefts, finger-like thumbs, and distal phalangeal and nail hypoplasias are known to be associated. So it's important that in the periconceptual management of women with epilepsy, one has to attempt to decrease the pharmacotherapy to monotherapy, taper the dosage of anti-epileptic drugs to the lowest possible dose, and in women who do not have a seizure for 2 to 5 years, attempt complete withdrawal of pharmacotherapy, establish the level of total and free aid is necessary for achieving good clinical controls, and consider genetic counseling, and most important, supplement the diet with folate at 4 milligrams per day at least is the dose. Now, ADAs are known to accelerate hydroxylation reactions in the liver by inducing microsomal enzymes, and folic acid being in the coenzyme is used up, and therefore there is a deficiency. So when we look at the critical window of opportunity for lifelong health, we definitely have to also think of the maternal nutrition in your history taking. Whether patients are taking proper nutrients, because it is now proved beyond doubt that pre-pregnancy, during pregnancy, and lactation, it is extremely important that the woman is taking proper diet with folates, folic acids, DHA, iodine supplements, and with well-balanced macro and micronutrient therapies, and LCPUFAs and healthy balanced diets. Because there are huge concerns, and it has been found that most of the illnesses that we suffer from today, from anemia to polycystic ovarian syndrome to obesity to diabetes to infertility and early infertility, all seem to be having some sort of an underlying oxidative stress due to micronutrient deficiencies and protein energy malnutrition. And therefore, this kind of an awareness is extremely important, that your daily diet consumption has to be containing all these kind of micronutrients. In the first visit, when we do the general examination, it's always a good practice to look at the body mass index, because we know that the increased BMI is responsible for miscarriage, gestational hypertension, preeclampsia, diabetes, and need for a cesarean delivery. While on the other hand of the spectrum, low BMIs can be for malnutrition, growth restriction, preterm delivery, PROMs, and anemia. Anemia is an extremely important, because oxygen carrying capacity happens to be important, And if it is not there, that gives rise to oxidative stress, improper implantation, programs the woman to preterm births, PROMs, and fetal growth restriction, makes us susceptible to genitourinary infections. And it is also important that we screen for thalassemia and sickle cell disease. Now, interpretation of these sonographies is important, and many a times we would have the gestational age not matching the sonographic age, and we are, along with the patient, worried. And we have to remember that if the rate of increase in the mean sac diameter is found to be less than 0.6 millimeters per day, increase of less than 3 millimeters over 5 days, or increase of less than 4 millimeters over 7 days, this pregnancy probably is not going to grow well, and there can be problems in this pregnancy further. Now, sonography in the first trimester not only helps us in screening for anomalies like cystic hygroma and encephaly growth restriction. Now, there's a huge body of evidence which talks about growth restriction in the first trimester of pregnancy itself, where you can identify that these babies are not only going to be growth restricted, but they are going to be programmed for future cardiovascular disorders. We can also talk of placentation, especially scar pregnancies with increased cesarean section deliveries, subchorionic hemorrhages, chorionicity, and morbidly adherent placenta. This is an interesting study put up by the workers here, where you can find here that in here you can find there is an intraplacental lacunar space seen in the first trimester, increased retroplacental vascularization and abnormal arterial trophoblastic blood flow. You can appreciate here there is an interruption in the bladder wall, and generally there is an irregular vascularization on 3D power ultrasound. Now, a lot of controversy exists, but it's always a good opportunity to look at this, because I showed you an example that we experienced. Because if you are able to find out that this is a map, you can give an option to the patient to go in for a termination of pregnancy, which can be done USG guided with much less morbidity. We also know today that cesarean scar pregnancy is a precursor of MAP, both sharing the same histopathology. Termination beyond 16 weeks, which is considered in severe cases with a high risk of maternal morbidity or mortality due to placental penetration, usually requires hysterectomy or hysterectomy or uterine artery embolization. And even if the woman chooses to continue a pregnancy, as was my patient, we can always help them with the early diagnosis to plan their deliveries better. There are so many other conditions, metabolic conditions, which are also responsible for all these issues which have to be looked into. And therefore, first trimester acts as a window of opportunity for optimization of the maternal health. You can see here Bebo, who is 39 years, married for 2.4 years, has polycystic ovarian syndrome on metformin, has conceived after ovulation induction, had 2 missed abortion, and is hypothyroid. And her labs have been normal, barring the fact that HbA1c is 8.4, and she is having diabetic profile, and TSH is 7.5. Naturally, the question comes, do we continue this pregnancy? Do we terminate? And what do we do next? According to the NICE guideline of the fertility problems published in 2013, it maintains that induce the patients with clomiphene or metformin or a combination of the above. And it is extremely important that the women are encouraged to lose their weight before restoration of ovulation. And what should be the extent of the diabetic control? The ADAC is aiming for a less than 6.5% prior to conception of HbA1c if safely possible. And euglycemia is known to reduce the risk of miscarriages and embryopathy. The ADA aiming for an AIC of is important. And now, preconceptional care for diabetes, has been found that if the woman is already pre-diabetic, it is important that she is screened for diabetic ketosis. Her fasting sugars are maintained between 80 to 90, and postprandial between 100 to 120. HbA1c should be less than 6.5, because that is known to reduce the congenital anomalies. And women who have HbA1c of more than 10%, it's better to avoid a pregnancy, because there are possibilities of rise in embryopathies. Now, poor control diabetes, there's increased risk of fetal loss. HbA1c level of more than 4 standard deviations above the mean showed higher pregnancy loss rates than women with low HbA1c levels. And subsequent analysis of this data set confirm increased loss at glycemic extremes. On the other hand, well-controlled or subclinical diabetes should not be considered a cause of early miscarriage. And especially we as a country, being the diabetic capital of the world, we have to be using this parameter a little more frequently and uniformly in our prenatal assessments. Apart from the first anti-neoplastics, there are 3 most potent human teratogens and isotretinoin, which is used for anti-acne treatments, alcohol, and hypoglycemia. And there is a risk of embryo-fetal harm from hypoglycemia increasing markedly when the HbA1c is greater than 8%. Diabetes, more than 90% of the harm caused by chronic diseases, and control of glucose levels in pregnancy is critical. So should we make any changes in the anti-hyperglycemic agents? Now, most women on oral anti-hyperglycemic agents should be switched to insulin, it is believed, because it's known not to cross the placenta and it gives us a flexible management. But near term, there is a possibility of neonatal hypoglycemia, and that can also be seen in OHAs if they are not monitored properly. But today we are seeing even the government of India recommends that we can very well try to control their sugars, especially in GDM mothers, by giving librolite or metformin. And that is something that we must be well versed with using. Obesity not only causes infertility, but severe adverse pregnancy outcomes, giving rise to serious maternal health consequences. While on the other hand, we can see that underweight women have other issues like preterm births and small for gestational age women. Women who have polycystic ovarian syndrome as a background have 40% risk of pregnancy loss, and therefore it's always better to encourage weight loss and give them insulin sensitizing agents at the time of periconceptional period and during and throughout the first trimester. In an endocrine etiology, evidence for early pregnancy loss is poorly controlled diabetes, overt thyroid dysfunction, elevated maternal TSH levels. Subclinical diabetes, luteal phase defects are no longer considered a common explanation except in pregnancies achieved with in vitro fertilization. Now you can see here there's a 33-year-old Gravida 3 which reports she had hypothyroidism, and naturally the next best step would be what? Begin levothyroxine, repeat TSH levels. So the answer to this would be, although the patient is asymptomatic, she has laboratory evidence of hypothyroidism and low free T4 levels. She also has elevated antithyroid peroxidase antibody levels, which indicates likely cause of her hypothyroidism. And she has to be continued on these medications, thyroxine. We can also consider giving in supplements of natural micronized progesterone, and this can be a patient for giving her low dose aspirin. So we have to look at the causes and the diagnosis of hypothyroidism and treat it appropriately. And the ACOG recommends that women should be screened throughout the pregnancy and especially in the first trimester for hypothyroidism. Now, if you look at the Mrs. CGH, she has come to us with 7 weeks pregnancy with a body mass index of 36, PCOS, hypothyroidism, hemoglobin of 10.5 grams, HbA1c 5.9, obesity is borderline. And when we look at her blood pressure, it is 140 by 90. She has conceived with clomiphene citrate with HMG and HCG. Now, whenever you diagnose hypertension, we have to identify that any blood pressure measurement of 140 by 90, any time before, during, or after pregnancy requires to be given attention to. And then we have to also think of various antihypertensive agents, whether she's already taking. Now, women who are already taking on hypertensive disorders treatment usually are taking ACE inhibitors or ARBs and sometimes even statins, and these have to be continued and switched. And we need to switch these antihypertensives to methyldopa and labetalol or calcium channel blocker agents. And what is very important to note is chronic hypertension in the mother itself is an important predisposing factor for congenital malformations, especially the cardiac malformations in the offspring, and this has to be remembered. And although it is possible that the hypertension increases the risk of the CHDs in the offsprings, it is also possible that hypertension and CHD share similar risk factors. So future pregnancy risks of gestational hypertension, preeclampsia, risk of complications like HELP, eclampsia before 34 weeks of gestation are phenomenal, and about 55% risk if it is found to be less than 28 weeks. Obesity increases the risk, and inter-pregnancy interval of less than 10 years does not increase the risk. So when we look at the genosis spectrum of disorders, it tries to explain everything. Women who have chronic hypertension, women who have gestational hypertension, women who have early onset preeclampsia, late onset preeclampsia, and the new observed entity today, the postpartum eclampsia, also are included in the genosis spectrum. Present screening methods have recommended, and with the SPREE study, we are talking of doing all lot of markers in the patient, and the question comes, yes, it is going to increase the sensitivity and the specificity remarkably to be able to analyze these diseases. And then if we already have women who we have diagnosed as high risk, do we really require to take them through all these gamut of examples? And what is more important is to identify that do we really need to do this ourselves, or we also need to educate women? Because if you look at the current, despite having such a large quantum, the know-how amongst the patient is extremely meager. And recent evidence suggests that we have two things in our hands which we can use, maybe the aspirin, and the other thing that we can use is calcium supplementations periconceptually. Having said that, we have such an access and identification of these gamut of markers that can be done, looking at the socioeconomic strata and the large vastness of a country, are we really ready to do this? And the answer to this probably is today I have so many patients calling me from various parts of the country and the state saying, we don't have access to NT, madam. We cannot do uterine artery PIs. What do we do now? So we have to understand that contingent screening is what the FIGO recommends. Do a proper MAP in all patients. Mean arterial blood pressures are very, very important. Measure them. If you have an axis of 12-week scan, look at the uterine artery PI. Maybe it can throw some sort of a inkling and some sort of thing. And if you look at the Australian government department health guidelines, it says the same thing, that it is important that we try to make these things cost effective. And therefore, it is important that we simplify these screening techniques much better to be able to give interventions during the first trimester, which will last them throughout the entire pregnancy. Knowledge is not enough, I understand, and experience is essential, but sometimes it's not necessary that you experience everything. There are so many of our other people working in the abundant countries who have experienced this. Let's just learn from them and try to extrapolate. And that's exactly what Justice India chapter has done by adopting simplicity. And after considering various guidelines, it has come up with a Justice score. And this is the simple Justice score, wherein you can look at the risk factors in the mother, and each of the risk factors has been given a score of 1, 2, 3, depending on its severity. And if you just do this as a risk score analysis at the time of history taking, when you assist your patient in the first trimester, when she comes to you for the first time, a lot of things will be over and you'll be able to offer them treatments. Now you can see there the parameters where I put these icons here. These are the ones which are clinically measurable. You don't have to go and find out, and the rest of them are all historical evidences which you have to ask the mother for. And if you allot them a risk score, even if the patient has one score, she requires to be given attention to. A patient who has score more than 3, you can very well start her on ecosprin, ensure that she takes proper diet and folate supplements and takes calcium. Now, what are the evidences? And there are various evidences which have supported the inclusion of these factors in the Justice score. Adolescent women or women who are older than 35 years of age have been found to be having more possibilities of preeclampsia. Obesity at a very young age, and especially women who are very short and very fat, are much at risk of preeclampsia. And obesity in a young age and compliance to folate supplement and adequate fruits consumption were found to be protective against preeclampsia. Likewise, if you look at nulliparous pregnancies, it was found that nulliparous pregnancies, there is a possibility of much higher inflammatory markers being there, making them at risk of preeclampsia. A maternal family history of preeclampsia, or in a primigravida, family history of preeclampsia in a family is an important risk assessment factor which can increase your suspicion and focus on the patient. Women with PCOS, much has already been said about it, are definitely at an increased risk for preeclampsia because of hyperandrogenism and insulin sensitization. And it has been found that sometimes women have their first pregnancy, then they take a lot of time. If they plan their pregnancy within 7 years, then they are probably protected. But if it goes beyond 7 years now, they are not protected for preeclampsia, and there is a possible rise of getting preeclampsia in these women. Pregnancies as a result of ART or IVF, especially ICSI, are much at a risk of developing preeclampsia. Probably this can be attributed to the background maternal factors also. Thyroid dysfunction, whether hypo or hyperthyroidism, both are contributory factors for occurrence of preeclampsia. Gestational diabetes mellitus has been found that 1.5-fold increased risk overall of developing hyper disorder of pregnancy, and multiple gestation also, because there is definitely more of placentation, more of inflammatory cytokines, and more possibility of these women developing preeclampsia. So statistically highly significant association between severe preeclampsia and maternal thrombophilia in white women has been seen, and with SLE has twice the risk of developing preeclampsia. Likewise, women who have schizophrenia or bipolar disorders have been identified to be more at risk of developing preeclampsia. Women with cardiovascular factors like hyperlipidemia are at risk of developing not only disorders now, but chronic hypertension post-pregnancy. So if you look at the rational gestational score, we have quantified the risk of preeclampsia according to individual clinical risk factors. In most of the other studies, every single risk factor is considered as equal. This makes a difference as far as preventive strategies are concerned, and it also helps in identifying clinical risk factors and serves as potential determinants of preeclampsia. And Snor and colleagues used a similar approach in ranking the top 10 risk factors for coronary heart disease, and a similar way can be done. Now, the basis of this particular score has been the meta-analysis published in BMJ 2018, which included 92 studies and so many pregnancies in 27 countries. And it was found that maternal risk factors can definitely help a clinician to identify women at risk and offer them corrective strategies during the onset of the labor, onset of the pregnancy itself, or at the time of the onset of the first trimester. So the prioritization of risk factors differed at the individual patient level, and women with rare risk factors like antiphospholipid antibody syndrome is certainly at higher risk, which is known. And even though the rarity of that risk factor makes it less of consideration, the reduction of risk of preeclampsia within the entire population, we can definitely earmark these patients and follow them properly. So there are certain risk factors which are identified to be having a much higher risk score, and sometimes helping them would definitely reduce the adverse outcomes that are associated with preeclampsia. The question comes now as to how much aspirin do we use? So there has been a randomized controlled trial, the famous aspirin study, which has spoken about 150 milligrams of aspirin and which was compared with placebo, and it has been shown to show some efficacy. And it's not today that aspirin has been proposed. There have been studies for a long period of time that have mentioned the efficacy of aspirin in trying to reduce the severity or the occurrence of preeclampsia. However, it is important to note that there is no head-to-head comparison or individual patient data meta-analysis comparing less than 100 milligrams versus more than 100 milligrams of aspirin. Either of these research methods would provide more robust data regarding optimal dose. So, initiate low-dose aspirin for preeclampsia prevention of gestation, and ideally prior to 16 weeks. Preconceptional also can be beneficial. Early therapy is important because placentation keeps on continuing till 16 weeks. And aspirin is not initiated at the end of first trimester. Initiation after 16 weeks, but before symptoms develop, may also be effective. Now, various organizations are using various aspirins. The ones which we can follow in our country is the WHO guideline, and the WHO is still recommending 75 milligrams of aspirin, while the Americans and the Canadians are talking of 81 milligrams or doubling it to 162 milligrams, and the European countries are talking of giving 150 milligrams of aspirin. So if you look at the conglomerate of the entire gamut of the first trimester, you start with maternal characteristics and medical history and use these basic blood parameters like complete blood count, TSH, serum ferritin, HbA1c, blood group, serology, serum creatinine, urine routine, and many a times you can also use this opportunity to do HPLC to screen for hemoglobinopathies, and according to me that's mandatory, but sometimes patients may not have an access to an HPLC, and it is important that this is done. Measurement of MAP can be done. If you have an access to the uterine artery pulsatility index and the PLGF, that can be taken and considered. But HTP score here would definitely help in identifying the maternal risk factors. And these are the women in whom you can follow them with a close surveillance. If they are found to be low risk, you can give them routine prenatal care. If they're found to be high risk, then you have to give them aspirin or calcium as is mandatory. Weight modification, set goals for patient in the first trimester itself. In an obese patient, she cannot put more than 7 to 8 kgs, while in an undernourished patient, she can put on till 12 to 15 kgs. The average weight gain during the entire pregnancy should not exceed 11 to 12 kgs. Anemia has to be corrected and screened for periodically. Iron deficiency is important because it can predispose the mother to preterm deliveries also. Calcium supplements is important. Micronutrients, folates, and DHA are extremely important. A lot of controversies exist around these things, but at this point in time, looking at various studies which have come from our country and looking at the basic undernourished kind of a category or malnourished kind of practices that we have in our country, we feel that these micronutrients are definitely going to be of help to us. Pregnancy nutrition should be fortified, fulfilled, and compliance assured. And the WHO ANC guideline says that even if you decide to give them 4 basic antenatal visits, it is important that at every visit, the woman is given a diet guideline and a diet compliance is assured from the patient. So by 3 methods, we may learn wisdom. First, by reflection, which is noblest. Second, by imitation, which is easiest. And third, by experience, which is the bitterest. Thank you so much for your patient hearing. And apologies for whatever we had hitches at the technical level, but I hope whatever we have recorded will be of great use to you. And I love to communicate because I'm a teacher and I love to share my knowledge. And always remember me. And whenever you get an opportunity to solicit a vote for me as the Vice President of Foxy, please remember my name. Thank you. This is Dr. Girija Wagh for you.
Madam, thank you very much for your lecture.
हाँ, कितना टाइम का हो गया रे?
मैडम, you are live. सब लोगों ने देखा.
Okay, but you said I was not live.
No, actually, in between the problem got solved. So
Okay.
you are live only, and people could able to see your presentation. And people have given some. They have asked some questions also.
Okay, so but we don't have time right now, correct?
If you want, I can read for you, ma'am.
I can. I don't have problems.
Okay. So. Ma'am, Dr. Vandana Vaibhav Gandhi, she has asked what dose, which salt, and when to start calcium so as to help prevention of PIH.
Okay, so calcium, to prevent PIH, we must start calcium if you have an opportunity before patient conceives. So 3 months prior to her conception, ideally calcium and vitamin D should be started. But if not, during the first trimester, all the calcium carbonate and the citric salts have been identified to be salts which are sort of category B salts. So in this time, during the first trimester, you can ask them to take calcium-rich diet. You can give them a diet which, and then vitamin D, of course, can be sourced from sunlight. It's believed that about 22 minute sessions twice in a week during 11 to 4 p.m. should be sufficient for them to give them vitamin D, correct their gastritis if they are having any, so that their inner bacteria will make the vitamin D for them. And then calcium carbonate or citrate, whichever you're giving, you have to find that the elemental iron that is being delivered to the patient is in the last quantity, and that has to be to the tune of 1500 to 2000 milligrams as per the WHO recommendation.
Okay. Another question is asked by Dr. Dattatray, and the question is, what is the protocol for recurrent pregnancy loss in first trimester?
Okay, so protocol in the sense that he wants to know, so the protocol in the recurrent pregnancy loss patient would be, first and foremost, you have to identify why she's having RPL. Many times it is those endocrinological factors that I mentioned. Sometimes we are only looking at the TSH level, but we require to look at the thyroid panel, completely. We also have to look at whether she has thyroid antibodies. They can be responsible. Obesity can be a reason, or maybe she may be having hyperglycemia. So if these are corrected, many times insulin sensitizers, DHA, folic acid supplementations, B12 have helped. Now, one more thing which I didn't mention here, which is very important, is many times we as clinicians tend to write pyridoxine as a treatment for pregnancy nausea. It has to be remembered that pyridoxine is a preventive measure. So you have to ensure that whenever the woman comes to you, start her right away with pyridoxine so that that will keep her emesis in control, and most importantly, that will also help her to take proper diet. So I hope this answers. We can also give them natural micronized progesterone. And if the patient seems to be having something similar to hyperhomocystinemia or any of these thrombophilias, then low dose aspirin can be started in this patient as prophylactic measure.
Okay.
There is one more question from Dr. Meeta Dogra. Is it required to add tablet progesterone to each and every patient in first trimester?
No, not necessary unless and until there is a clinical evidence suggestive of something suggestive of a luteal phase defect. As I had said, that unfortunately now this terminology is not defined and not understood, but then it is believed that there is some sort of an anti-progesterogenic action. And there has been study by the Ismail group which has come up with identification of various kinds of inflammatory cytokines, which were studied in the first trimester, second trimester, and third trimester. And they identified that when natural micronized progesterone was started in the first trimester, these women had a much reduced incidence of miscarriages because it causes inflammatory modulation. So probably that can be the reason why natural micronized progesterone can be of help. To an extent, it can also help in modifying this inflammatory response and even reducing the probability of preeclampsia, but we require to have evidence to say this with confidence.
Dr. Chitra Shankar is asking, does low sodium salt intake help? Please elaborate. A patient frequently asks question about this diet, about the diet.
Now, the most important thing which we understand is none of the recommendations say that takes low sodium in your diet or cut down the salt. See, whatever salt intake one is taking, one can take that. But do not have additional over the table salt. That is what we must tell to our patients. And please note that 25% of our preeclampsia patients and obesity patients have chronic hypertension. They may be having an underlying hypertension and essential hypertension, and therefore it is mandatory that we have not a restricted salt, means not completely a salt denuded diet, but little bit of restriction of salt is important. And secondly, it's always better to give them a potassium balancing diet. See, most of these vegetables, salads, they contain a lot of potassium. Whenever a sodium has to be excreted out of your body, potassium vehicle is essential. And if this is followed, then most of the patients, in fact, many a times I have observed in my patients that with proper dietary guidelines, sitting across with them with a pen and pencil and guiding them, it has helped them in reducing edema, reducing their obesity. So many patients tell me my weight has not increased, doctor. I said, don't worry, your baby is growing because you are eating well. So these important things are essential. That we must identify that weight is a very arbitrary marker. We have to look at how the woman is taking. So that's how about salt restriction.
Okay, madam.
Hello.
Okay, madam. And last question from Dr. Promila Malik. She's asking the role of low molecular weight heparin in APLA positive with bad obstetric history in previous pregnancy with ecosprin 150.
Yes, actually most of the studies are saying that both together are found to be much more beneficial rather than, and any one of them is also found to be beneficial, but both together are better. But we cannot just give low molecular weight heparin and say all the other things that I mentioned are extremely important. LMWH has been found to be sort of helping in preventing the placental apoptosis and the thrombosis. Rohan, so therefore, it is important that that is been given correctly. Answer this one, please.
Okay, madam. I'd like to thank you, madam, for such a wonderful lecture. You have covered each and every aspect of obstetrical care in first trimester. I hope audience has gained a lot of insight. I would like to thank all our participants for taking the time out for this webinar. I also like to thank our BU head, Mr. DP Saptati sir, and divisional head, Mr. Manish sir, for making this event possible. Have a nice day ahead. Thank you, madam. Thank you so much.
Thank
Thank
you.
you very much. Thank you very much.
Thank you so much. Thanks, Satan.
Yeah, ma'am.
Bye, Pati.
I can leave the meeting.
Yes, ma'am.
Thank you.
Thank you, ma'am. Thank you very much.
Thanks, Satan.
हो गया उसका